So it gives me great pleasure to welcome our first speaker today, Ben van Calster from KU Leuven and LUNC Leiden. I imagine most people are very familiar with Ben's work, both through the methodology in prediction modelling, some key papers that I'm sure we're all aware of, and also through applied work. I think, still working on projects on ovarian cancer. So those of you involved in rockets will have worked with Ben. So I'll keep it short. And today you're talking about uncertainty in clinical prediction models. So we'll aim for approximately 40-45 minutes and then have some time for questions at the end. So welcome, Ben.
Okay, thank you very much. Thanks for having me. I will be talking about something that I also presented at last year's ICB. It's about sources of uncertainty in clinical prediction models. It's not very difficult in my opinion, so I mainly work towards an illustration of these sources of uncertainty. Now, I think at ICB I had to talk 20 minutes, so I added some stuff and we'll see where we end today. So yeah, a short introduction. So usually when we have a risk prediction model, we validate that on a population level in terms of discrimination, calibration, clinical utility. That's also what tripod and so on and other sources recommend. But of course, in practice, if you use a model, patients only get their own risk and they're only interested in their own risk. So the question is then how correct is that risk? How uncertain is it? Actually, if you think about how we develop models, so I came across this figure in Ewout Sterberg's book. So you have some kind of superpopulation, and these patients, they are seen in various settings, various countries, and you can collect various samples from various settings, and then you can develop various models from various samples from various settings. So I think the sources of uncertainty are more or less, as I thought, elephants in the room, and I find this nice painting that had exactly this title with elephants in the room. So I think we've kind of ignored it or not paid so much attention to these sources of uncertainty in the last decades. That's my opinion, at least. In recent years, there is more interest in it. But I mean, if you take 2 minutes to think about it, they've always been there. It's nothing special, nothing new, I think. And in 2000, in the famous, one of the famous papers from Doug Altman, Patrick Royston, they wrote, "We believe that the distinction between what is achievable at the group and individual levels is not well understood." But if you look at some papers from the past, some papers hinted at the issue. So you have these paper from Limshow. I always wonder how to pronounce his name. I hope that's more or less correct. From some tests that we do not recommend you to use, where they write alternative models while demonstrating good agreement for describing patients in the aggregate are shown to differ considerably for individual patients. That was in 1995, and in 2005, Henderson and Keating wrote, "Human survival is so uncertain that even the best statistical analysis cannot provide single number prediction of real use for individual patients." That's strong statements. So of course you can go into the philosophical discussion of what individual risk actually means. And it's a heavily debated concept, and this slide seems to give the impression that I've read all these old books from philosophers on probability. Of course I haven't, but I have been Googling around quite a bit to understand what people have been writing about it. So you have a lot of people saying that it makes little sense. You have this reference class problem where in the end you can put any patient in an infinitely large different number of groups, and so it is impossible to really fine-tune the context of an individual patient to some kind of thing as a risk. But it has also been said that a risk estimate can be seen as some betting level that you can use. And some people find that concept quite useful. But apart from that, we're not going to delve into the concept, the philosophical concept of an individual risk. We will just focus on how uncertain is this betting level, if you wish, that any model gives to you when you happen to be on the receiving end. And so I distinguish here between 4 sources of uncertainty. So the first 2, you see them quite regularly in papers here and there: aleatoric uncertainty and epistemic uncertainty. For example, the paper by Hullermeier and Wageman in machine learning discusses these 2 types of uncertainty. But you can also think about other levels of uncertainty, such as data uncertainty and population uncertainty. And this is also hinted at in another paper that I think is still only on arXiv by Gruber and colleagues, where they discuss these topics as well. Yeah, so aleatoric uncertainty is, you could say, irreducible uncertainty. So if you have different patients with the same values for the predictors in your model, they can still have a different outcome. So the variance of y conditional on x is larger than 0. And you may say that, well, the higher the AUC of a model, the lower the aleatoric uncertainty is, because then more patients have very high or very low risk estimates. But that's just something you have to live with. You have people with the same predictor values, and they can still have a different outcome. And then epistemic uncertainty is uncertainty caused basically by lack of knowledge. You can call this reducible knowledge, because of course knowledge may increase or may change over time. And you can decompose that into approximation uncertainty and model uncertainty. And I also added modeler uncertainty to that decomposition. I will shortly go into that here. So approximation uncertainty, which has also been labeled estimation uncertainty, it refers to the stability of the result if you have a given modeling procedure. And maybe simplistically, you could say that this refers to sample size. So if you have small sample size and you fit the same type of modeling procedure, then depending on the sample that you happen to have drawn from the population, you may get very different risk estimates for the same individual. You can quantify that kind of instability with bootstrapping, and Richard and Gary have written a nice paper on it. And I mentioned another citation there on the slide because that's a thesis student of mine. We were doing something similar, but I had to stop because Richard and Gary were faster. And I could spend my time on other projects, but that's the way it is. So stability also varies individually. So you can think about the CI, the confidence interval that you can get around the risk estimate for a regression model. That may vary for different individuals. So you have patients with a very typical covariate pattern, and you have obviously patients with a more atypical covariate pattern where the confidence interval will tend to be larger. The model uncertainty is the second type of epistemic uncertainty, and that refers to the fact that we do not know what type of model we should fit. We do not know what the true model is, conditional on the predictors. We do not know the real data generating mechanism. So we have to do something sensible. You know, the quote, all models are wrong, and so on and so on. In addition, there's also uncertainty about which predictors to use, or the set of predictors that we start with in our modeling procedure. But closely linked to that, I think there is also something like a modeler uncertainty. And so the modeler has to make a lot of choices to turn a set of predictors into a model. And also, if you have to choose which predictors to start with, you also need to make some choices. And some traditional things are, how do you deal with continuous predictors? What do you do with the functional form there? What algorithm do you use? And now with the popularity of machine learning algorithms, this becomes more prominent. And so modelers can handle model uncertainty differently. You may read the same literature, but have different opinions about it. We have different favorite methods that we like to use. And modelers also often use wrong or suboptimal methods, as we see in the several systematic reviews that people also here have done and published. And you may say, well, you should not dichotomize continuous predictors. That's fine, people do it. And they also get a model that gives risk estimates. Then you have data uncertainty. So that refers to things like measurement of predictors. So you can have different definitions, as we will see later. So if you use tumor size as a predictor, you may define that as the maximum diameter of the tumor, or you may define some estimate of the volume of that tumor. Apart from that, there is also measurement error, and maybe in particular measurement heterogeneity between settings that plays a role. You can think of similar things for the outcome. So think of these images where they do deep learning on, and sometimes the outcome of the images has to be determined by some experts, and you can imagine that there is quite some uncertainty there. Obviously, the very annoying problem of missing data, and the underlying mechanisms. Why is it missing? How should we handle that? How we handle that, that's more like a modeler uncertainty kind of thing. Everything is related. Censoring in prognostic studies, what's the reason for censoring, and so on. And study design characteristics, something as simple as inclusion and exclusion criteria, also cause some uncertainty. And finally, you have population uncertainty. Different centers, different countries vary in a lot of respects, the case mix of the population. Also, something annoying there is treatment pathways. Well, it's annoying statistically, it's a fact of life, and you have to think about it. A lot of things can vary between hospitals, and so on. And then there is the population drift over time. Populations are not fixed and stable, but they change. But there are a lot of things that can contribute to the uncertainty when you're trying to develop a model. And I will try to illustrate that. Maybe it's impossible to comprehensively illustrate that. So, I mean, I don't have a data set where I can show everything that I've mentioned as possible contributors to uncertainty. But our ovarian cancer data can help to illustrate some things. So I started with data from 1,100 patients, women with an ovarian tumor, from our hospital in Leuven. There are patients that were scheduled for surgery. You can discuss about that, but let's not do that for now. It gives us histology, so we have an outcome, benign or malignant. There's also, it's not perfect histology, but it is pretty good generally. And we want to develop a model to estimate the probability that the tumor is malignant or not, to guide subsequent clinical management. And so I define a main model, modeling strategy. So let's say I use standard logistic regression with, 5 continuous variables, 4 continuous variables, and 2 categorical variables, so 6 variables in total, where the continuous ones, I model them with restricted cubic splines for 3 months. There I made a choice about the functional form, but that's the choice that I made. So I'm a good boy, I use the sample size methodology that people want me to use. And I try to implement it properly, and it says minimum required sample size 350. Okay. So I have a total data set of 1,133. I take randomly 100 patients once as a fixed test set. It's too small to evaluate performance, but I'm not interested in the overall performance. I'm interested in risks for these 100 individuals. So I thought a set that is small is acceptable for this illustration. That leaves me 1,033 patients as my training pool, and I randomly select 385 cases from the training pool, which is a bit higher than the minimum sample size when I used the sample size methodology. I have some missing values, so I have to deal with that. We know that it is almost certainly missing at random, the missingness mechanism. So we use, I used imputation here using regression imputation. I will not detail the imputation model that I have, but of course you have to make some decisions there as well. So I trained the model. First I impute, then I train the model on the training set, and then I apply the imputation model on my test set and the fixed 100 patients, and then I apply the prediction model to the test set. So that's how I handle the missing data in the test set. So I apply the imputation model first, and then the prediction model to get risk estimates for it. So I get my risk estimates for the 100 patients in the test set. Then I decided to have 10 variations regarding how I model the data. So, for example, in terms of nonlinearity, so functional form for continuous variables, I could have decided to use first-degree fractional polynomials instead of restricted cubic splines. I can ignore nonlinearity, and we generally don't advise to do that, but it happens. And I also dichotomized variables at the median. Okay, terrible, but I did it nevertheless here. I could do this without being prosecuted. And then I also decided to do some backward elimination, once with alpha 1%, once with more flexible alpha 20%. I also decided to use penalized estimation based on the corrected AIC from Harold, so I didn't have to tune a lambda parameter in a rich model, but this went faster. I also decided to, for one variation, to include interaction terms with one of the predictors at the C1 to 5 level, and do backward elimination on the interaction terms only with the 20% alpha. We could have done this in a very different way, but okay, that's a choice I made here. Then I also decided to fit random forest models instead, ones with very deep trees, so the minimum node size of 2, and ones with less deep trees, minimum node size of 20. And then I made also a model where I used 2 different categorical predictors than the one used in my main modeling strategy. So I applied these variations one at a time, so I didn't combine them. Then I had 3 variations regarding data uncertainty. So once I modeled tumor size and the proportion of solid tissue using the maximum diameters. That's my main modeling strategy. And the variation is that I model these variables using estimated volumes. And then there are also some variations for the missing data. So I used the missing indicator method once instead of the imputation, or I used median imputation conditional on outcome. We don't advise on that either, but it was fun to do that. It goes very fast. And then 2 variations regarding population uncertainty, where actually I fitted my main modeling strategy, but then on equally large training data sets one's from a hospital in Rome and one from a hospital in Malmö. The test set is always the same 100 patients from Leuven, always. But sometimes my training data set are from another hospital. That also happens in reality. And for approximation uncertainty, so the instability, I did all of that 100 times. And so I have one main model. I have 15 variations that I do one by one. So I have in total 16 models. And I fit those 100 times with 100 randomly drawn training sets of 385 patients. So in total, I fit 1,600 models. And then I apply all of these models to my tested patients. So the x-axis on this plot is a patient index, and the y-axis gives me the estimated risks of all 1,600 models that I fitted. First, something shortly on overall performance. So the mean AUC in the test set of these 1,600 models was 0.97. This was a bit uncomfortable. We know that in our ovarian tumor studies, we regularly get AUCs above 0.90. 0.97 is very high, and a lot of people say, well, if I see that in a paper, I don't believe it. I'm one of them. But here, I just had 100 randomly drawn patients, and I think I was lucky in the sense that they were a bit better distinguishable in terms of their outcome than in the complete population. But yeah, on the other hand, it can also be convenient because I actually have a problem that is prediction problem that is very easy. The AUC is almost perfect. The second statistic that I show is the estimated calibration error, which is a statistic from the machine learning community. I regularly, normally don't use it. But here, this was just some measure of calibration that was easy to get. And on average, the estimated calibration error is 0.07. I will not go into details on how that is calculated and so on. I just wanted to give some indication of overall performance. So calibration was generally roughly not horrible. Maybe very, I don't know how to put it else in a different way. But what you see there in the plot is 100 patients with 1,600 different risk estimates. And for every patient, you can calculate the risk range across the 1,600 risk estimates for that individual patient, which is the difference between the model that gave the highest risk of malignancy minus the risk of the model that gave the lowest risk of malignancy. And on average, the range of the risk estimates for these 100 patients was 52 percentage points on average. And it ranged from 5 percentage points for these patients all the way on the left in the plot to about 1. So the risk estimates were anywhere depending on which model and which training data set you were using. And so the uncertainty in the risks for the individual patients is very large, even when we have a model with an almost perfect discrimination, where you would think, well, yeah, the uncertainty will be lower here. I mean, it's quite clear. And for most of these patients, even you and me, I think we're all methodologists. You see the ultrasound image, and even I can say, oh, yeah, that's benign. I don't need any model. So it is, for a lot of tumors, it's quite easy. Even we can do that. But even then, the uncertainty is so large. So I thought that was, in the end, an advantage that my AUC was so high. But if I just look at the instability, so I fit my main model, that I used 100 different training samples drawn from the total sample that I had, then I get this uncertainty. So this is now only 100 models from the 1,600 in the previous plot. There you see that the mean risk range, just by drawing different training data sets, is 20 percentage points already, the range from 2 to 74. Now you can also focus only on the variations in terms of the modeling procedure, so not in terms of imputation or population or definitions, but just what did you do with variable selection? What did you do with nonlinearity, with interactions? Did you fit a running force or something else? So if I only show these results, so if you remember, I had main model and 10 variations in terms of model uncertainty and modeler uncertainty. And I show here 11 risk estimates for each of the patients. So I fix the training set to the first randomly drawn training set here, so I don't repeat it. Then I get this uncertainty on the plot. So the mean risk range is similar, again, 20 percentage points between the risk from the model that gave the highest risk and the risk of the model that gave the lowest risk. And finally, data, not finally, I have one plot here. So for data uncertainty, if you remember, I had 2 different ways of dealing with missing data, and I had a different definition of tumor size. So 3 variations plus my main model. So here I show 4 risk estimates per patient. And for these choices, I mean, there could have been many other choices. The uncertainty was smaller. The mean risk range was 6 percentage points. And then here for population uncertainty, so basically you have a training model based on data from Leuven, or a training model based on data from Rome, or a training model based on data from Malmö. and you apply these three models that you get to the same test patients from Leuven, then you get this uncertainty. I had thought that that would be bigger because, you know, population differences can go in all possible directions, but it also means that if you use three hospitals, that you can be lucky or unlucky. But, right, so that was basically what I presented for ICB. I don't know what time it is now. Yeah, so I have some time. So that's what I added yesterday. Some results from a case study that I've been working on last year. And this is a study where we made a prediction model for non-typhoidal salmonella bloodstream infection in young children in Congo. It was a single center study in Congo. And it was they needed a model to decide which antibiotics to suggest for these children. So there were children from almost newborns up to 5 years. We had a data set of 2,327. It was one of the best data sets I'd ever seen in terms of quality. It was fantastic. If everyone comes to me with a data set like that, I mean, my door is open. I'm afraid to take on new collaborations for consulting because you never know what you're going to get. So I was very scared when this PhD student walked into the room and she had read stuff. She had used PM sample size. Like, so, okay, you did everything. So decision curves, yeah, I know, I've read it. And she had a whole SAP and I read it. It was like, restricted to XYZ. It was perfect. I just had to program it in R. So these collaborations are rare, but they happen. Anyway, we had 295 patients with the event. So this type of bloodstream infection. And 70 parameters we wanted to look at. So I asked Richard, is it okay if I make the model? And Richard said, that's fine. You have enough data. I actually had 500 patients more than the minimum requirements. So not 500 patients too much or too many, sorry. It's more than the minimum requirement, right? So we went on with it, and I got the optimism corrected C statistic of 0.79 and a slope of 0.95. And I have these, what's that, the violent plots of the risk estimates for the patients with and without the infection. Here as well, the plot does not come through the way I want it to be, but you can see the violence, so it's good. And here I did this, how do you call it in the paper? It's an instability plot. Yeah, I did exactly that. So you can see the enormous instability that you have with a data set of 2,300 patients. I think we did things properly, and the instability is enormous. And the risk threshold that the clinicians thought was probably the best one, you can have discussions about that, was 20%. So I drew a horizontal and a vertical line at 0.2. So you can see how often a model based on one sample would give a risk estimate above 20%, whereas a model from another sample would give a risk estimate below 20% with exactly the same modeling procedure. So that is quite a lot of instability there. We've added such a plot to the paper. Okay. Then what's interesting here is they also wanted a score system. Generally, I would say, no, don't do that. You're going to lose information. But they said, yeah, where this model will be used, we're not sure about the presence of the right equipment to calculate the risk estimate of the model. So, and I thought, well, that's a good reason. So let's try to make a score system to help them out. So I did all of that. I will not go into detail, but that's what the scoring system looks like. So you have age on admission, fever duration on admission in the model, whether a patient is admitted during the rainy season and so on, malnutrition, malaria status, and so on. So you get the points depending on which value you have for all of these predictors and so on. Interestingly, you can then make a scatter plot of the risk estimate that you get from the developed risk model and the risk estimate that you get from the derived score system. And the C statistic for the score system, optimism corrected, was 0.78. For the model, it was 0.79, so it's about the same. You lose very nothing in terms of discrimination. But if you look here at the level of uncertainty that you add here, it's quite substantial, I would say. So if the model says that the risk is 40%, the score system can go from, let's say, 10 to 50% roughly. It's basically the same model where you just cut it into pieces, and that's another way you can create uncertainty in risk estimates. So I thought it was interesting to show that. Now it is 34. Yes. So I have a second case study to illustrate it on real projects that we are working on at the moment. And that's about pregnancy of unknown location. I don't know if people know what that is, but we always use data from England, so it's very common here apparently. In Belgium, nobody knows what it is. So apparently these are patients that are pregnant, but on ultrasound they can't locate the pregnancy. Very short explanation. And so the key concern is that this can be ectopic pregnancies, where it's a bit more difficult, where you have to look for them anywhere, but not in uterus. And these patients need closer follow-up because you can rupture and so on. And so we had a data set of almost 3,000 POL from 8 centers, so all UK, as I said, and 334 were ectopic pregnancies, and a few of these were actually persisting POLs. Very bizarre for me to understand what happens in the end. You have to know what happened, but apparently some rare cases remain a mystery. But they assume that these are often ectopic pregnancies that in the end just disappeared. Anyway, other outcomes were that the pregnancy was a failed POL or that it was an early intrauterine pregnancy. So it was a multinomial outcome. So we fitted models using 6 algorithms. So multinomial logistic regression, the rich variant of that, and then random forests, XGBoost, neural networks, and support vector machines with tuning of the hyperparameters in the machine learning models. And then we validated these models on data, new data from one of these 8 centers, St. Mary's Hospital. So they had 822 new POL, of which 86 ectopic pregnancy. So probably for a real validation assessment, sample size is we looked at that using found some paper on determining sample size for external validation of prediction models with a binary outcome. I wrote that, but I used it. And so it's insufficient for calibration. But again, for the purpose of today, that doesn't matter so much. And so here you see the validation performance of these models. So you have the multinomial C statistic is about the same for all of the algorithms. And the C statistic, or the AUC, for ectopic pregnancy versus other outcomes, which is the key thing we're interested in, is also very similar for models. We have some calibration curves for the estimated risk of an ectopic pregnancy, which are for the lower range where most of the risk estimates are roughly similar. You can see that the rich is actually penalizing too much. So the risks are the variability of the risks is too small here. But for many of the models are similar. And then here I give the scatter plot of the estimated risk of ectopic pregnancy for all pairs of algorithms to show the uncertainty for individual patients. And so that's below the diagonal in the plot here. And above the diagonal, I show the percentage of patients where the risk estimate from 2 algorithms is on different sides of the common decision threshold, which is 5%. If the risk of ectopic pregnancy is 5% or more, we suggest more intensive follow-up of that patient. And then you see that for some pairs of algorithms, even more than 30% of the patients, the model would suggest a different clinical management, even though the same variables and so on. And then here, if you look at the range of the risk estimates for individual patients, then you could see that for 14% of the patients, so 1 in 7, then the estimated risk of an ectopic pregnancy varied by more than 20 percentage points between the 6 algorithms. So there is again quite a lot of uncertainty here. And here the AUCs for ectopic pregnancy were close to 0.9. So again, discrimination performance would generally be labeled as good, even though we don't like labels for AUCs. And with the discrimination is quite substantial. And here too, you see quite a lot of uncertainty simply by the choice of the algorithm. So some conclusions. There are a lot of sources of uncertainty here. I think it's important that several people involved in developing or using or implementing models should be aware of that. I think you can discuss a lot about how this affects the way we communicate risks to patients who already struggle a lot with just interpreting a percentage, let alone if you give a confidence interval around a percentage, which is only part of the uncertainty that you can think of. And quantifying uncertainty completely is impossible. And so stability is only a part of uncertainty. It's really like these instability plots, like the one I just showed. So stability only is often, or instability only is often quite substantial already. Sample size methodology is of course great. I think what you've seen in the last couple of years is really a big step forward. So talking about EPV is now almost a crime, but that's fantastic. But I mean, there are a lot of things beyond that that are maybe not difficult to put into numbers. And then you have these methods that you see in the machine learning literature, where they sometimes include the option for the model to abstain from a prediction. So you have these models that classify patients into high risk or low risk. So in clinical terms, treat or not treat. And then if, according to the algorithm, the uncertainty is too large, based on some quantification of it, then the model is able to say, I don't make a prediction, I'm too uncertain here. These are nice ideas, but that's fairly simplistic if you think about all the sources of uncertainty that come into play. But I mean, it's not to downplay all of that stuff. I mean, it's just, as I say, quantifying uncertainty completely is impossible. I used the word multiverse on this slide. I'm not sure whether it applies correctly, but it sounds like a cool word to use. So epistemic uncertainty, that's something that's under the influence of the modeler. So you can think about the issue of sample size to reduce instability. We can make bias variance considerations. But if you have to make too strong of these considerations, and maybe your sample size is just not good enough for doing something reasonable. There is domain knowledge about predictors that evolves over time. People should have some basic knowledge of prediction modeling. So that refers to modeler uncertainty. So people do all sorts of things in studies, and some things are really not ideal to do. And then finally, maybe it again demonstrates that it is important to focus on heterogeneity between settings when you develop and validate a model. So that's the IPD study design is great for that, or just multi-center studies are nice for that. And you can look at distribution and effects of covariates between settings and so on. And again, it shows once more that model updating is something, is a useful tool, and that maybe we should use them. And then I had here, I tried it in another presentation, and whether that works, it's just a small, I don't know, the sound works. It's nothing important. But the sound doesn't work. Yeah, I don't know. We can try for half an hour to make the sound work. The point is, it doesn't work. It was a nice quote from House of Cards. So you may have seen that years ago already. I'm always a bit behind from watching stuff on Netflix, where that guy says analytics. Oh my God, what does that even mean? And if you see all the uncertainties that come into play, I think that quote fits. I keep saying it. Okay, and then here's some literature, relevant literature on uncertainty, including instability and so on, that I came across when preparing this. And that's all I had to say.
Brilliant. Thanks very much.